Good afternoon. My name is Lee Saltz, and I'm Vice President of Advocacy for the National Council of Jewish Women Los Angeles. And on behalf of the National Council of Jewish Women Los Angeles, I'd like to welcome you to our Breast Cancer Awareness Educational. For those of you who have never been here before or who've never attended our events, I would like to tell you a little bit about our brown bag educationals and who we are and what we do. This organization is over 100 years old, and lo, for these many years, we have worked for very basic principles: advancing the well-being and status of women, advancing the well-being of children and families, enhancing the quality of Jewish life, ensuring and advancing individual and civil rights and freedoms. Across the country, October is Breast Cancer Awareness Month, and there are free events all over the country, just like what we're having here today. But we at the National Council of Jewish Women Los Angeles are especially fortunate to be able to have such auspicious co-sponsors of this event. Our co-sponsors are the City of West Hollywood, Cedars-Sinai Medical Center, and for those of you who have not had an opportunity, do take the Wasserman Breast Risk Cancer Reduction. They have a program. I just took the test. I've never taken that test before. It's really lots of fun. So these are the people who have put this program together for us to educate you. And before I introduce our moderator for today's program, I would like to take care of some housekeeping chores. You're all sitting on chairs, and under those chairs are lots of papers. And we didn't put them there to make the seats softer for you. We put them there so that you can be informed about the people who are on the podium, who will be part of the panel, and also to inform you about some events that will be taking place here at our council house. There is also a yellow card there with an evaluation. And I know that when you're ready to leave, you say, well, I got to run, I got to go, but please do us a favor, fill out the evaluation card. It's so important to us because we really read them, and then we try to use the information from the cards in how we plan the rest of our programs. If you like what you see and what you hear today, and you think, hey, I'd like to be part of that organization, we are a very vibrant organization, and we welcome you with open arms. You don't have to be a woman. You don't have to be Jewish. All you have to do is say, you know, I like what that organization does, and I want to be part of what they are doing. We are an equal opportunity organization, and there is a table out in the hall with membership applications, and Pam Brown, Pam, raise your hand, will be more than happy to help you and give you any more information that you need about joining our organization. It's now, oh yes, okay, because I have so many things to do, I have to, okay. On your chair is a green sheet, and this green sheet tells you about our clothing giveaway, which will be taking place in December. Volunteers are needed for our annual clothing giveaway on Sunday, December 4th. Please join us to give clothing items and children's books to more than 5,000 individuals in our community. Volunteers are also needed the day before the event to help sort out the clothes and the books. Volunteers must be at least 12 years of age, and the phone number of who you call if you'd like to be one of the volunteers is on this green paper. You will also find on your chair information about the first Jewish Women's Conference of Southern California, which is coming up this Sunday right here at Council House. It will be from 8:30 to 2:30 p.m. And if you'd like, you can gather with us to hear amazing speakers and participate in very important workshops, meet other Jewish women who want to make a difference here and in Israel. The opening keynote speaker is Mayim Bialik, whom you may know from the television show Blossom and The Big Bang Theory. And I'm making a strange face because I don't really know those shows. But tickets are $36 a person or $18 for students, and admission includes a light breakfast because you got to get up early. You need to be here by 8:30, and a boxed lunch. There are just a few seats left. We're just thrilled with the response that we have gotten. So again, there are brochures out in the lobby, and we would love to have you join us. Our next event in terms of the advocacy program is going to be just a phenomenal event. It is something we have been planning for a long time. This is what it looks like on your chair. And it is Life on the Streets, Homeless Women and Children. Now, I don't know if any of you were able to catch Michael Moore last night on Pier Morgan, but talking about homelessness and life on the street is now just, oh, those people, because those people are now we people. So we are very excited about this program. We've worked very hard to put it together, and on your program it will tell you who the speakers are, and of course the challenge now, which is even more than we had anticipated, is the fact that we have female troops that are coming home in December from Iraq. What is going to happen to them? There are already lots of homeless troops. And so these are the issues that when we say we try to deal with the issues that affect women, children, and families, these are all covered in everything we're doing today and everything we're going to be doing at this event. It is now my pleasure to introduce the moderator of today's event, a woman who I just have gotten to know since I've been here at Council. And she always amazes me with her knowledge and how wonderful she is in presenting information or moderating a topic. And of course, that's Council Member Abby Land, who has been a resident of West Hollywood since 1979, so she must have been there when they were just starting to put that wonderful city together, and she has played an instrumental role in the city since its inception. And of course, for those of you who know her, you know she wears at least 15 hats, but she is an elected official. She serves as co-chief executive officer of the Sabin Free Clinic. She's a recognized leader in healthcare management. She is one of the state's leading advocates for universal health coverage. And in addition, she has spearheaded innovative efforts in the area of domestic violence, which is another area that we work on here at Council, including same-sex domestic violence, breast cancer, lesbian health, overall health, wellness programs in the city. I don't think there is one area that Abby has not put a finger into. And she's also widely known for her leadership on women's issues, LGBT rights, civil liberties. She serves as a member of the Los Angeles Department of Health Services Women's Health Policy Council. And that's probably why her marriage is so good, because she's never home. So we'd like to welcome Abby Land.
Great, I was wondering what the secret was. Thank you so much, Lee. I really appreciate it. And I am a proud member of NCJW, and if there's anyone sitting in this room that isn't, you should be, because it really is a phenomenal organization. And I'm incredibly proud of the partnership that the City of West Hollywood has with NCJW. I'm proud of the partnership the clinic has with NCJW, because we work together on a number of items. And I'm also very proud of the partnership that we have with Cedars-Sinai Medical Center, because Cedars is a community player in so many ways, and helping put this together is just one of many ways that Cedars participates in the community. I want to give a couple of thank yous before we begin the formal presentation today. I want to thank a number of people who worked to put this together, not only the folks at NCJW, but I also want to thank the Breast Cancer Awareness Month Committee. That was Logan Williams. Is Logan still here? He's somewhere. There's Logan. Ruth Williams from the National Council of Jewish Women, and our own Heidi Schink from the Human Services Commission in the City of West Hollywood. And of course, our staff at the city, Leslie Eisenberg, Corey Roskin, and our intern, Andy Lavano. We really thank you all for your efforts. This is just one activity of a month of activities that have happened, and I want you to know, if you go to City Hall, there are a lot of resources at City Hall, from shower cards to pins to information. Here at NCJW, there's a lot of information, and of course, we've had the wonderful opportunity to have the Wasserman Breast Cancer Risk Reduction, not easy to say so quickly, survey kiosks that were at City Hall. They're here, and I really do encourage, as Lee said, to go ahead and take the survey so you can really understand your risk for breast cancer. It's really important. And we're also encouraging women to sign up to be part of the Army of Women. This is something that was started by Dr. Susan Love, because what she recognized in research, that sometimes the hardest part is finding the women for the research. And so by signing up, you're not ever agreeing that you want to be part of a research community, but what it does do is it allows, when there are opportunities to do research and they really need very specifics, they have this army of women to go to. So I really urge you to sign up for that if you would. So breast cancer, my mom is a breast cancer survivor. So breast cancer is something that, knock on wood, I've had to have, it's in my family, but we have had a survivor on that. Breast cancer is the most common cancer in women worldwide, and it is the second leading cause of cancer death in women. And that's really important to know. We should all know that the #1 cause of death for women is actually heart disease, but the second largest killer for cancer is breast cancer. In Los Angeles County alone, there is an average of more than 1,000 women who die from breast cancer each year. After increasing for more than 2 decades, female breast cancer rates have actually begun to decrease a little bit. So that's really good news. But in 2011, it's estimated that there's still going to be over 230,000 new cases of breast cancer in women in the United States. And nationwide, we will probably lose about 40,000 people to breast cancer. Breast cancer doesn't just affect women, it affects men too, but we will talk a lot about breast cancer in women. But the good news is, because of the number of women receiving mammograms every year, more cases of breast cancer are found at earlier stages, and they can be treated easily and more successfully treated. The 5-year survival rate for all women diagnosed with breast cancer is about 89%. And they're beginning to do more studies about survivors as well, because the good news is we now have many folks who have successfully fought cancer, and so that's the good news. But there's still so much for us to learn about breast cancer. My mom is a survivor. My husband's daughter is a survivor, and she got breast cancer when she was just in her 30s. So it is still a disease that we have so much to learn about. There is a pamphlet at your chairs that give you extensive biographies about the experts that you're going to hear from. So I am not going to read those, or else we take the entire time just reading these biographies. But I am so thrilled with the panelists that we have, because they really cover the range of the full discussion that we need to have about breast cancer awareness. And what we're going to do is I'm going to introduce each panelist. They'll tell you a little something about themselves and what they do, and some of their thoughts on this subject. And then we'll have some dialogue, and we also will have some index cards that we'll be passing out. And if you have a question, please write it down. Write as legibly as you can. But you're doctors, so I can give it to you and you can read them. And I should have been a doctor, because I can't read my writing at all. But anyway, please write as legibly as you can, and then we'll try to get to the questions, because I know that is always really the part that comes. So again, please do read their bios. These are the most impressive group of doctors, and for all due respect to the men in the room, women rock. Okay, so let's start with our first presenter, and that is Dr. Michelle Bernsen. Michelle?
Good morning. It's a pleasure to be here. Thank you for the invitation. And I'm a radiation oncologist. I was trained at UCLA. I served there 15 years as an attending physician, and then I came to Cedars about 11 years ago. And over the years, I've developed particular interest and passion for radiation for breast patients in particular. So with that, I'm going to just give you a little bit of an overview about radiation therapy, really brief, and then to get into areas of research that I think are important and that we're still learning about and pursuing. So radiation therapy, like surgery, is a local form of treatment. And the indications are generally when we think there's a very high suspicion that there's little cells that may be left behind after the gross resection of a tumor, whether it be in the breast that's remaining, or the chest wall, or the regional lymph nodes. Now, it's best given in the curative setting, if there's small cell deposits, because a basic tenet of radiation is that it works very well with little disease, because the bigger the bulk of tumor that you're trying to aim at, the higher the risk for complications in the adjacent tissues. So many years ago, it was shown that if you give about 6 weeks of radiation therapy, same dose each day, you get about a 95% chance of sterilizing microscopic deposits. So that's been our tenet for 50 years, or so to speak. So in terms of generalities of research and development, in radiation, it's generally concentrated on two arenas. One is technology, which is our basis, and then specific patient selections in terms of defining who's best treated with radiation and who may not be, given different options. So with that, with patients who have a mastectomy, for instance, which was prevalent more than 20 years ago as a standard of care, it was developed that if you had high-risk features, that a 6 weeks course of radiation should eradicate disease. And nowadays, in the last 20 years ago, we developed CT scans where we can actually visualize where the beams are going, and so we can avoid tissues at the same time. And then about 10 years ago, we had IMRT, a new technology that can target even more specifically areas and, again, improve the efficacy of targeting and yet minimizing risk to tissues in adjacent areas. In terms of patient selection for mastectomy, the recent research arenas are looking at constellation of risk factors in patients who don't meet standard criteria for post-mastectomy radiation, but who have molecular profiling that would predict that they are indeed at higher risk and that we should be pursuing that. So that's what we're really researching now. More relevant today's standards is breast conservation, with the intent of preserving the body image and helping people heal and get over this insult. And so that really came off the arena about 20 years ago, with some three great studies that showed that it was just as effective as mastectomy. So in recent years, the thrust of radiation has to develop new technologies and methodologies in that arena. And in particular, for instance, there's 3 different situations. One is now that we're trying to condense the 6-week course to maybe, a 3-week course, and so there's been data that's accrued that's shown that you can give a higher dose per day and effectively do the same amount of cell kill without damaging the tissues. And then there's an arena where it's condensed into 5 days as opposed to 6 weeks, which is called accelerated partial breast radiation. And thirdly, there's intraoperative radiation therapy methods now that have been developing that maybe for some selected patients, you can just give radiation to the surgical bed right at the time, one-stop shopping. You know, each one of these different methodologies have very strict credentials that you have to meet to be better served with one or the other. And the ongoing protocols now, you know, are looking into those arenas, and we're developing that here at Cedars. So that's the overall of where we've been and where we're going.
Great, thank you so much. It's just so great to see how technology has really influenced and made better and hopefully less invasive, you know, the impacts of breast cancer. Our next speaker is Dr. Catherine Dang, who is actually the Associate Director of the Wasserman Breast Cancer Risk Reduction Program. Doctor.
So I'm a breast surgeon, so what I do is I take out breast cancer, whether that be with a lumpectomy, where we're taking out the cancer with a little bit of normal tissue in the breast, which is something that has evolved in the last, 25, 30 years or so. And we also still do mastectomy, but that is also evolving. Nowadays, we're saving most of the skin of the breast. Sometimes we're even saving the nipple. And Dr. Nguyen will talk about reconstruction options, which are also evolving. We're also taking out fewer lymph nodes sometimes in certain situations for women with breast cancer. With that comes less risk of swelling of the arm, which is called lymphedema, which people who've had lots of lymph nodes are at risk for. And patients seem to get back to their normal activity faster with less surgery. So I'm a surgeon by training, and I got into this because my mom is also a breast cancer survivor, and she's been alive and well and disease-free for 24 years. So
That's great. You know, people choose the areas of medicine for different reasons, and many times it's because of a personal experience. So thank you for sharing that. Dr. Aura Gordon, Director of the Gen Risk Adult Genetics Program and Genetics Director of the Wasserman Breast Cancer Risk Reduction Program. Aura.
How's the volume? You guys hear me? So I'm a geneticist, a medical geneticist. I run the hereditary cancer prevention and hereditary adult disease prevention program at Cedars, and consider myself sort of the final frontier in prevention. About a decade and a half ago, 2 genes were discovered that had a tremendous impact on the risk for hereditary breast and ovarian cancer. It's long been observed in Jewish women that there was an excess of breast cancer and ovarian cancer. These 2 genes, which have been called BRCA1 and BRCA2, had a profound influence on understanding why Jewish women seem to be higher risk for these 2 diseases. Now, it's very important to understand that all women in every corner of the globe are at risk for hereditary cancer as well as sporadic cancer. But understanding when there is a family history, and sometimes even when there isn't a family history, but there are particular features, such as what Abby was talking about in terms of her stepdaughter having very early onset breast cancer. Even if there was no family history, this would be a cardinal sign that we'd say, we need to look into this. You're sort of too young to get environmental cancer. So this has opened a whole new domain of investigation, and there are these specific genetic tests which can be offered to women who are at risk. More and more, we're sort of generalizing that. The data shows that it may impact a very large number of women with breast cancer even without a family history. As much as 1 in 10 Jewish women who have breast cancer may carry one of these genes, even if their family histories don't seem that compelling. 1 in 3 Jewish women with ovarian cancer carry these genes, and 1 in 10 ovarian cancer patients of all races and creeds probably carry one of these genes. So that has had a very profound impact, and we spent the last decade and a half refining management. How do we prevent cancer in people who have an elevated risk? How do we identify those women who are at higher risk? What can we offer them? Do we change our treatments related to people who have hereditary versus sporadic cancers? What has surprised people is that in the last kind of decade that there haven't been additional high-risk genes that have explained more and more of the breast cancer. So what has changed in focus is now really looking at, well, what is the combination of sort of our genetic load, the deck that you were dealt, and our environment, and how does that weave together to predict risk. Part of what the goal of the Wasserman program is to try to thread that together in women who don't come from these remarkable family histories, but may in fact be at elevated risk. Can we pinpoint other features of their personal, their reproductive, their environmental, and their genetic background to better identify who needs higher risk screening and who perhaps doesn't need high risk screening? The last couple of years, there's been a lot of discussion about, do we need to roll back the mammograms? And there was a big, furor in the end of '09 that suddenly, we were going to be taking away the annual mammogram from our ladies. And what we recognize is that it's very much individual, and that's what we're trying to do. Figure out what's tailored, what's the best thing for each individual woman and for our men who are at high risk too. So that's what I do.
Thank you. Thank you. I have a feeling we're going to have a lot of questions about that and how to understand, for yourself, decision-making processes. So let's go to our next doctor, and that is Dr. Dung Young Nguyen, who's going to talk a little bit in the plastic and reconstruction aspect of this.
Can you hear me okay? So I'm a plastic and reconstructive surgeon. I recently joined Cedars-Sinai Medical Center. I trained at the University of Southern California. And then after that, I completed a year of specialty training in reconstructive microsurgery. So my areas of specialties includes all forms of reconstructive surgery. In particular, I deal with complex reconstruction involving microvascular free tissue transfer. That means taking tissue from one part of the body and then moving it to another location and then reconnecting all the blood vessels. And we do that frequently for breast reconstruction, among other types of reconstruction. My other areas of specialty includes surgical treatment for lymphedema, particularly for patients post-ablative cancer treatment. And more recently, in the last recent years, as you know, the categories of breast reconstructions are threefold. One is implant tissue expander-based reconstruction. The other is autologous tissue transfer, which we use your own tissue, either keeping it connected to your to the blood supply, or disconnecting it from the blood supply and then moving it to the breast for reconstruction. And the third option is using a combination of tissue expander or implant with your own tissue. And the categories for breast reconstruction have not changed much over the years. What have been evolving is the technique by which the tissue are being, being harvested or being taken from the site, the donor site. And in particular, more and more we're moving towards doing what we call perforator flaps for breast reconstruction. And what that is that instead of just taking skin and fat and then muscle, which traditionally has been the method of breast reconstruction, autologous breast reconstruction, we're moving more towards just harvesting the skin and the fat and preserving all the muscles at the donor site. In addition, the donor sites that are now available for us that we can reliably give you a good reconstruction not only comes from the abdomen. That's the traditional donor site where we take tissue from the belly and then we give you a tummy tuck as a result. But nowadays we can reliably reconstruct and give good breast reconstruction using tissue from the medial thigh or the lateral thigh and the buttocks area in selected patients who do have excess tissue in these regions. And they can give very good shape and projection just as the abdomen. The other area that's new is surgical treatment for lymphedema, which it's an old topic, but recently over the last 5 years there's been a lot of development in terms of techniques on how to reliably improve patient outcome using surgical procedures. In the past, as you know, the main form of treatment is either compression garments, massage therapy that's done on a regular basis, and or if the condition is very severe, patient may require large resection of tissue and then skin grafting, which leaves significant morbidity and donors, morbidity and complication as a result. In the last recent years, due to advances in microsurgical techniques, we've been able to bring forth two types of treatment. One is called lymphatic venous anastomosis. Basically what it is that we identify small lymphatic channels that are present in the affected limb, and then the adjacent venules, the veins that are on the, that sometimes we see on our arms or on our lower legs. And then under microscopic assistance, we reanastomose or make a cut in the vein and the lymphatics, and then reconnecting them, vein to the lymphatic and the lymphatic to the vein, vice versa. And what that allows is that it allows the lymphatic fluid, which normally is has nowhere to drain as a result of cancer or tumor resection or radiation, scar tissue, now has ability to drain and bypass that obstruction and drain into the venous system directly. So that is very effective for early stage lymphedema. The other is vascularized lymph node transfer. And what that involves is taking lymph node from one part of the body where it won't negatively cause lymphedema in where the donor site is, and then removing that tissue with its blood supply and then transferring it to the affected limb. And that has also been shown to be very effective for even a little bit more advanced stage of lymphedema. And both of these techniques can be done in conjunction for severe stage lymphedema with reasonable good result, at least much better than our conventional treatment.
Thank you, and thank you for breaking it down in a way that those of us who aren't doctors could actually understand what all that meant. Thank you so much. Our next panelist is Dr. Dorothy Park.
Hi. I'm a medical oncologist. Most of you probably will know I'm the one who gives chemotherapy. So as you can see, that treatment of breast cancer is a really multidisciplinary field where you need army of doctors as well as the nurses and nutritionists, the social workers, and the whole group of people are involved in taking care of people with breast cancer. As far as the medical treatment of breast cancer is, I guess, sort of divided into group of people who have early stage breast cancer who needs therapy after surgery and or radiation to prevent or to decrease the chance of having breast cancer come back. And that part of the medical treatment is called adjuvant therapy. Sometimes we give chemotherapy before the surgery to shrink the tumor to make the surgery easier, or to be able to have a breast conservation. Sometimes we do treatment after the surgery to, as I said, that the goal of the therapy is for cure and to decrease the risk of relapse. And then there's other group of women, more, I guess perhaps less fortunate, who have more advanced disease where they are diagnosed at the stage where it's already spread outside of the breast, where we try to give what we call palliative therapy. Our goal there is not necessarily for cure, but again, we're giving treatment to decrease the cancer burden in the body, therefore decrease the symptoms it might have from the disease, and the whole lot of other psychosocial issues that goes along with it. We give medical treatment as well as trying to help them live with a cancer, because it is true, even when it is advanced and spread outside of the breast, some of the breast cancer patients can live years. I've seen people who live more than 10 years with breast cancer, needing treatment on and off. So this is another area that we don't always talk about a lot, but a fair number of women going through this and needs a lot of support. As far as the treatment, different treatments that are available for breast cancer, now we have traditional chemotherapy that are designed to kill the tumor cells. So that would be mostly what we think of it as a chemotherapy drugs. And then there are hormonal therapy, where if your breast cancer has hormone receptor positive, then we can try to manipulate the hormonal system. So mostly these are pills, although we do have an injectable. And then there is a whole other group of treatment where we call it more of a molecularly targeted therapy, where one example would be Herceptin. This is an antibody treatment that's directed toward HER2-positive breast cancer. And there are now more drugs that are being developed, as well as studied. There's a whole bunch of different class of targeted drugs that are being developed. One area of research would be that most people feel hormonal therapy is easier and less side effects, but unfortunately, sometimes hormonal drugs, it works for a while and then people develop resistance. So there's an area of research where we're trying to overcome that resistance. So that would be another area. Other would be, some of it has been already discussed, that we're trying to personalize to individual patients, because not all of us are the same. Not all of our cancers are the same. And so we're trying to better define each breast cancer in each individual, trying to find what type of therapy would be more effective. And so that's a whole area of new research.
Great, thank you so much for sharing that. And last but certainly not least, it's always tough when you come at the end, but I want to introduce Dr. B.J. Rimo.
Hi.
Doctor.
So I'm a gynecologic oncologist, and I deal mostly with the bottom half of the bikini. So one of the things that we do as part of breast cancer involvement is that some patients can't take hormonal therapies for their breast cancer, and sometimes removing their tubes and ovaries is beneficial to them, and that type of surgery is performed by our group. The other thing that we do that sort of rides along with breast cancer is that with these hereditary breast and ovarian cancer syndromes, we treat ovarian cancer both with surgery and with chemotherapy. Ovarian cancer is the 5th leading cause of cancer death in women, and about 20,000 people are diagnosed every year. So it's actually not nearly the scope as breast cancer. But because we know that these two cancers sort of run along together, for patients that have these gene mutations in BRCA1 and BRCA2, as Dr. Gordon mentioned, those are areas of research for us as gynecologic oncologists. We have a research program currently at Cedars called the Gilda Ratner program, which is looking at women who have BRCA mutations and have had breast or ovarian cancer, and we're continuing to do research into things that may play a role in what we call the penetrance of those genes, environmental factors, location factors, nutritional factors that may make a difference in when one person with that mutation might get a cancer at 30 and another mutation might not get a cancer till 70, how we could sort of predict those things. And lastly, sort of like things that are interesting in gynecologic oncology, people frequently ask me, well, can we screen for ovarian cancer? We know we have mammograms and breast MRIs and things for breast cancer, but can we screen for ovarian cancer? And unfortunately, right now, that's simply not the case. We have many, many large-scale trials, and one of the largest is this recent trial called the PLCO, or the prostate, lung, colon, and ovary. And the ovarian screening suggested we actually did more harm trying to screen women than benefit. The reason being is the prevalence, the amount of people who get ovarian cancer every year is very low. And so we're doing more surgeries than we really needed to do to detect some cancers. So it was about 8 women were getting surgery for every 1 woman who actually had a benefit of cancer surgery. So those are sort of what's going on in our group.
Great, thank you very much. Again, if you have questions, I think there are some note cards, so please write them down or raise your hand and we'll make sure we get them to you. And just to start off, I'm going to ask stupid questions probably, but so talk to me a little bit What's the difference or not between like why you get radiation, why you get chemotherapy, how they're the same, how they're different, just so everyone can understand the terminology. And Dr. Bernson, why don't I start with you?
Well, basically, you think about it as the volume of cells that you're trying to eradicate. So surgery takes the clump out. We take care of the regional, which is probably a higher volume than you think might be in the blood. So they're overlapping. More recent, in the last decade, it's been validated that chemo does impact locally as well, but you still need the radiation probably because there's a larger tumor volume that needs that extra kick.
Okay. Anything to add, Dr. Park?
Yeah, I sort of, as Dr. Bernison said, that we think of radiation more as the regional chemotherapy or hormonal therapy are what we call systemic therapy, meaning we're treating the whole body. So we're trying to take care of a few other cells that might be floating around outside of the local area and trying to get rid of that by giving chemotherapy or hormonal therapy. Great. So sometimes you need both.
Mm-hmm. And often they work together. I mean,
right,
chemo
exactly.
can potentiate the effects of radiation, and you get more for your given dose, so to speak.
Yeah, great. And I think what's interesting. It really does take an army of doctors to address. And I think what's different now than many years ago is it's not one size that fits all, and that really trying to customize is very helpful. We talked about, Dr. Gordon, you talked a lot about the genetic impact, and I've got a few questions here around if you find you have that gene, what's the deciding factor about if you get a mastectomy or not? And certainly in the news lately, there have been celebrities who have come out and have said, once they got that diagnosis, they made that decision. So maybe you could talk about that. And if anyone wants to add into that discussion, please do.
Yeah, it's a very personal decision, and we always think about it as sort of the trident fork of options. It's increased surveillance, it's medical prevention, some of the hormonal manipulation that Dr. Park was talking about, we offer that to women. This is talking about women who don't have cancer, who are suddenly faced with the information that they're at very high risk. And so a lot of it rolls into where they are in their place in life, what are their goals in terms of family planning, their life planning, the burden of risk and how they perceive that. So that is very much an individual choice. And so it's that screening, trying to do something stepping up in between. Sometimes people make the choices to take out their ovaries, for example, which reduces their hormones if they're before the age of menopause, and it gives them benefit for their breast cancer risk, very profound benefit too, or surgical prevention. And again, it is sort of an army of people that care for women who are at elevated risk. And so a preventive mastectomy is a very different operation than one being done for cancer. The reconstructive choices are, we can have the speakers talk to a little bit, and Dr. Nguyen, Dr. Dang, that gives a much broader option. Yeah. And often when people make that choice, of course, they decide to take both breasts and reconstruct. And in my patient population, there's very high satisfaction when women choose to do that because they feel very unburdened. The data on the risk after a preventive mastectomy is a little hard to measure, but is probably less than 1% risk for breast cancer. So far less than the average woman walking around lifetime risk for breast cancer.
Great, thank you. And maybe if you could talk a little bit about if, and of course, for everyone it'll be very different because you'll talk with your doctor, but maybe some general things if indeed you find you have the genetic cell and you visit your surgeon and I guess maybe together the reconstruct. What are some of the questions we would need to be asking so that we would make sure that we get the right kind of surgery for the right kind of reconstruction? So maybe some guidance as to questions we should be asking the doctors.
I think that, you know, if you don't have a diagnosis of breast cancer, you have to go in and you're considering doing a preventative mastectomy. I think you have to understand what your expectations are and what you have to ask, what kind of surveillance will I be recommended to have? You know, because after mastectomy, we generally don't do mammography anymore. You rely predominantly on clinical breast exam, meaning an exam by your physician. We also occasionally do imaging like ultrasound or MRI even after mastectomy. It depends on your level of risk. And then you also have to ask, you know, what the major question that we are faced with now for women with BRCA positive and doing prophylactic surgery is whether or not to save the nipple. That's a big consideration because we can save the nipple technically. We are leaving a little bit more breast tissue behind because we need to in order to keep the nipple alive. But cosmetically, it looks very good. It's your own nipple. And Dr. Nguyen can describe, you know, they can reconstruct nipples and do reconstructions of the areola, tattooing of the areola as well. But that nipple doesn't have any function, and some people tie in the sexuality is an issue that we don't really discuss that often. And I think patients are hesitant to bring that up with their physicians, and so a lot of young women are facing this, and their partners have to get involved in the decision making as well.
Anything you wish to add?
I just want to add that in terms of from a reconstructive standpoint, when we see a patient for consultation for breast reconstruction after resection, one of the key factor that we would like to know is whether or not additional adjuvant therapy will be required after surgery, in particular radiation therapy. Now that's an issue that is still controversial among plastic surgeons around the country and around the world as to if you know the patient is going to get radiation therapy, would you go ahead with immediate reconstruction versus delaying the reconstruction? And there's pros and cons to that, but in general, if possible, less complications and better outcomes, you know, more often than not occurs if we do the reconstruction after radiation. The reason being radiation causes skin changes and tissue to shrink, scar formation, and so it affects not only all types of reconstruction, whether it's implant-based reconstruction or autologous tissue or a combination. And as a result, patient most likely will end up requiring an additional procedure either to revise the reconstruction or to change it out completely and do a new reconstruction. So it's an added operation. The other thing is that we do know from preliminary studies that some of which are coming out from MD Anderson that saying that having a reconstruction at the site where a patient is going to receive radiation therapy, it does affect the absorption, you know, the effects of the radiation on the tumor bed. And if we know that ahead of time, that's something that I'd like to, you know, consult with the patient, of course, with the oncologist and the breast surgeon as to perhaps delaying the procedure until all treatments are completed before we proceed with reconstruction.
Great, thank you. I have a question. Of course, I want to remind everyone that the doctors aren't here to give exact medical advice because they don't know any of us. But I think the question, you can give some opinions about it, which will be great. But again, so one of the folks said that she actually has calcium deposits in her breasts, and she's taken mammograms, of course, for many years, and she does say she doesn't think a woman invented that machine. But, but she's now 87. And so she feels like she just doesn't want to do any more mammograms. And so kind of what's your opinion of, you know, mammograms and age? When do you stop? When do you start? And she has, you know, this issue. So anyone. And we can have a few different opinions. That's okay. In fact, make up some different opinions.
Part of what I do as a breast surgeon is that I follow a lot of women who are considered high risk for breast cancer or who think that they're high risk for breast cancer, and they don't have breast cancer. And a lot of them, you know, we all get older, and at some point, the reason we do mammogram screening is to detect cancers early enough so that we don't have to do that it doesn't, so that the cancer doesn't impact the probability of living X number of years. So there is some data looking at the benefit of screening mammography in women over the age, I believe, correct me if I'm wrong, it's like 75. It's actually pretty young, considering the life expectancy of women in this country now. So it's a discussion that each patient or each person should have with their physician. And I have patients that are in their 80s, probably like 81, late 70s, that decide, I don't want to have any more screening mammograms. That doesn't mean that they don't get checked. They still go to their doctors. They still come see me once a year, get a physical examination, but they don't want to do screening mammography anymore. And I do support them in that.
Anyone else want to weigh in?
Well, yeah, I think in general, it all depends on not just what all the mammograms showed, but also your general health status. So the only reason we do screening mammography is to see whether we can find a cancer early so that we can impact on, on survival. So, if somebody has a 10-year, 20-year or more life expectancy, we want to find it early so that we can treat it early, and therefore it won't affect the survival of that patient. But if your general health is not very good, if you have other medical issues, I think a lot of those things sort of impact on your decision to go ahead with doing mammography or not. And I think that decision should be made with your own personal physician.
Okay, great, thank you. I know when they've done some studies in the past, they said that lesbians are actually more prone for breast cancer. Do any of you have any information on that topic or know why that would be?
It's obviously not related to their sexual orientation. It's related to your hormonal status and having had full-term pregnancies. So any woman who has not had a full-term pregnancy and who's not had a full-term pregnancy under the age of 30 is at slightly increased risk. And so then also just depending on what other hormonal environment you've had may influence that.
Great, thank you very much. Someone's asked, did you either state or can you talk about that CAT scans are ineffective for diagnosing ovarian cancer or cancer in general? And so maybe you might want to talk a little bit more about that.
Sure. So CAT scans or CT scans are x-rays of the body, and they do it sort of in slices, like you'd slice a loaf of bread. And that's how it's done. What it gives is a lot of information about things that are about as big around as your thumbnail. About a centimeter is what we say the cutoff is for most CT scans being able to see something. What we're learning about ovarian cancer and tubal cancer and primary peritoneal cancer, which also run along but are extremely rare, with breast cancer, is that these cancers are not as likely to start as masses that you can see, but rather sort of what we call either a field effect or an effect where it's sort of like sand in the abdomen, and those tiny little bits of sand will eventually grow bigger over time and may be able to be seen by CAT scan. But in terms of diagnosing an early ovarian cancer, it's very, very difficult to do, even with MRI, even with PET scan, which is where we give a radioactive tracer, even with ultrasound, which is looking at a completely different modality. It's just been very, very hard. And all of the large-scale studies that have looked at different imaging types and modalities have been really ineffective in picking up this sort of sandpaper early disease that would really make an impact in the patient's survival. So where research is headed, rather than towards imaging, is actually towards blood testing. So people have probably heard about CA-125s, and that test was actually developed almost 25 years ago. And as good as CA-125 is, it's also positive in liver disease, heart failure, all kinds of other things. So it's not a specific test. And in large-scale studies, both here and in the UK, we haven't found any consistent benefit to following CA-125s. So we continue to struggle with finding new markers, new things that we believe are likely to be blood or serum-based And there are large-scale studies continuing both on the Pacific coast with the novel markers trial, and then nationally looking at something called proteomics, trying to look at your body's entire span of proteins and seeing if we can pick out tiny little variations that might make a difference in our ability to screen.
Great, thank you. Are there differences in detecting cancer in women who've had breast implants, and are there other concerns that differ for women who've had breast implants that we need to be aware of?
Well, I think that any woman who has breast implants, when you get your first mammogram or whenever you go for your mammogram, they make you sign a release that says there's a possibility of rupture of the implants. That is pretty unlikely. I personally have never seen it happen at our mammography center, but so it can impact the quality of the mammogram because it does make it a little bit more technically challenging for the mammography technician to get all of the breast tissue in the field of the mammogram. But that being said, not really. And there are people who, you know, having the implants pushes the breast tissue towards the surface sometimes, and sometimes it actually makes it easier to feel a small lump. I've taken care of a young woman who's 31 years old, went in for an augmentation with implants, and then she noticed her lump after the swelling from the surgery went away, and sure enough, that was a cancer. Wow. And she was way too young to get a mammogram, no family history, so this is what prompted her to get her treatment, and she's doing fine.
Great. Okay. Did you want to add?
Yes, I just want to make a comment that with regards to breast implant, there is no statistical significance in terms of whether or not there is an implant there or not in terms of detecting cancer. However, if there is a capsule, capsular contracture, which is scar thickening around an implant, that can in some way obscure visualization of the mammogram. So having saline versus silicone alone makes no difference. However, if there is a thick capsule around and the breast is firm and hard, that can obscure visualization and detection.
Great. And maybe can you, somebody talked about it earlier that, you know, a couple of years ago they came up with new ideas of when women should be screened, et cetera. I know that they've changed kind of reimbursements for doctors through different government programs about that. Can one of you talk about what's the new recommendation as to when, and I know, you know, certainly you consult with your doctor, but overall, what are the new recommendations? Because it's not now that you should get them every year, and what are the ages? And so whoever has that latest info or wants to say, this is my opinion on that latest info.
Well, it's kind of controversial because different societies have different recommendations, and that's the problem. You know, the government with the United States Preventative Task Forces, they said basically that women between the ages of 40 and 50 really shouldn't be getting screening mammograms, and between the ages of 50 and 60, they should have it every other year instead of every year, and after 60, every year. So that's, and then none after 70. That's the other thing too. So 75. But the Society of Breast Surgeons, American College of Radiology, the American Cancer Society still supports annual screening mammography beginning at the age of 40 for the average risk woman. What the U.S. Preventative Task Force also did say to kind of cover themselves is if you have family history or other risk factors that may increase your risk for breast cancer, you should discuss having the screening mammograms with your doctors at an earlier age. But so far, insurance carriers, to my knowledge, have not denied doing mammograms for women between the ages of 40 and 60 on an annual basis.
Anyone else? I think everyone agrees on that. And there are some state programs actually that help low-income women. There's a program called Every Woman Counts, and though I think in a way they move more towards what's recommended, there still is an opportunity for providers to work with a woman, and based on her history, the state will still pay for that through FPAC, which is and Title X funding, which is around women's health, again, for low-income women up to certain levels of poverty. They still have access, and Every Woman Counts also deals with cervical cancer as well. So there are some places for low-income women for certain to get help, along with, you know, being able to go to great places like Cedars. Someone asked about, and I can't exactly read all their writing, but I know where they were headed, and that was looking at other treatments, not taking the radiation and chemotherapy. And, you know, there's been a lot about alternative treatments. Certainly we know with the loss of Steve Jobs and his fight against prostate cancer and some of his treatments. So, you know, alternative medicine and Western medicine need to always work hand in hand as much as possible. But do you have any thoughts on these cleansing treatments, taking extra vitamins, any thoughts about that, even maybe as prevention? Are there any studies out there that show if we eat something better or drink something better that we have a better chance of not getting breast cancer?
Who wants to tackle?
I'll have a bit of a crack at that. Well, as far as cancer prevention, if you are not already diagnosed with breast cancer and your idea of doing something right so that you won't get breast cancer, I think that you know, always when I discuss this, the rule of thumb is it's a common sense. Everybody knows what good diet is. Low fat, high fiber, you know, lots of fresh vegetables, not so much prepared food, processed food, and so on. And your best source of vitamins and antioxidants are from food source. So I sort of have a general discussion of that. In general, many of the studies done, nutritional studies that are done in large scale, trying to find certain vitamins or certain antioxidants to see whether if you had increased amount in your diet or through supplements, whether that improved reduction in breast, you know, in general cancer risk. It has really never panned out. There are some studies that actually showed increased incidence of cancer after such a study. And so in general, yeah, my recommendation always is healthy diet, lots of exercise, you know, and not so much depending on the supplements. One big study that has really shown that these lifestyle changes have improved breast cancer recurrence in general is a large study where they've looked at women who had an intervention after having had a breast cancer diagnosis. They did one group of patients where we told them, these are good diet, you should have a low-fat diet, and you know, you sort of gave a general, simple recommendation, where the other group, there was a more intense intervention with the nutritionist sitting down, going over your diet, and trying to achieve a very low-fat diet. Percent of fat calories in your diet was reduced as low as to about 15%, which is very low. Most of our diet in the United States, your fat calorie intake may be as high as 40% or higher. So these women really did make an effort to have a low-fat diet, and their risk of breast cancer recurrence was much, much lower. Right. I mean, the degree of benefit was toward more what we see in medical interventions. So I think that's sort of a incentive for all of us to try having a healthy diet, and that's sort of the discussion that I usually have.
I think that it's very complicated, right? It's your diet and everything that goes into that. Weight. So in terms of what are the things that you can have impact in, weight loss or the reverse. Excess weight is clearly associated with increased risk. So women, particularly postmenopausally, who gain weight have higher risks for breast cancer. So whatever you can do to maintain an ideal body weight throughout your life cycles is very important in terms of prevention. That's not to beat yourself up if you can't do that, but even achieving small, moderate changes helps in terms of both prevention of recurrence of breast cancer and occurrence for the first time. Same thing with exercise. And I always tell patients, they sort of, particularly non-exercisers or people who have failed and challenged with their diets and those kinds of things, is that, you don't have to have the end goal being the New York Marathon. If you move 15 minutes, if you go from nothing to 15 minutes a day, you decrease your risk for diabetes, your blood pressure, all of these things which are these metabolic pathways which all seem to feed into the same thing towards chronic disease of aging. So, you got a lot of bang for your buck if you can just take one step forward to taking a step forward. That's what I try to do in terms of empowering and engaging my patients.
Great, thank you.
And a colorful diet. That's what I do.
I'd like to add just one
Yeah,
tiny
sure.
thing. So for prevention of ovarian cancer, we do know that use of oral contraceptive pills, the birth control pill, even just using it for a year can reduce your overall risk for the next 10 years of developing an ovarian cancer of 50%. We don't get quite that much bang for our buck for a lot of other interventions. And although it's not really an alternative treatment, it is sort of a nice window into some of the things that we're trying to do for chemoprevention.
And a lot of women are very worried about the birth control pill
Yeah.
and their risk for breast cancer. And so we spend a lot of time telling them, first of all, the prevention in terms of the ovarian cancer, the power of that prevention from ovarian cancer, even in ladies who are at high risk, who have hereditary breast cancer susceptibility, they're far better off with birth control pills than not. The new formulations of birth control pills have so low, their hormones are so low that now we're sort of watching to see whether we might even reduce breast cancer in the future because they kind of are underbarred what our own bodies can produce in some way. Most of the data has been pretty complicated in trying to figure out birth control pills and breast cancer risk and hormone replacement. Nobody's asked that question. I can't believe nobody's asked that.
I still got these cards.
And the duck and run, right? Because so.
Well, why don't you just answer it now then?
Okay.
So we'll...
All right. So the pendulum has swung. And I've had to reverse, in my own clinical practice over, 15 years of being in training and in practice, from if you left my office without a prescription for hormone replacement, the OBGYN attending would beat you over the head, to, that it's the pariah and we're pouring poison into our ladies, right? So neither of those are really the truth. It is not the elixir of youth and is not the reason why women remain vital and sensual and intellectual. If you don't have hormones, you don't shrivel up and turn into a prune that can't write a sentence. But it has a very powerful impact. You like that visual?
Yeah. I'm going to hold on to that, thanks.
But we have such a relationship with our hormones, that we as women, dread this idea of that when we no longer are producing our hormones, at this sort of the big slide towards the end. And so the hormone replacement story is so long and so complicated. The best I can give you for kind of what happened from the Women's Health Study is that it's pretty clear that chronic use of hormones, so more than 5 years of combined synthetic hormone replacement, increases your risk of breast cancer. And what kind of sealed that story from every way that we looked at the statistics one way or another is that when that study came out in 2003 and everybody went whoosh and poured their pills down the toilet, the breast cancer rate fell in this country. So it's one of those slides where when you show that graph and you say what happened and then the 30% reduction in new incidence of breast cancer, you go, okay, that's pretty compelling. What is long-term, short-term? There's some evidence that anything less than 2 years probably has no impact. So women who are having horrific hot flashes and are just miserable and they can't sleep, hormone replacement is really effective for the management of that. We have a pretty big armamentarium. We have a lot of other things that we can offer women to help them sleep, to reduce their hot flashes, to help them feel well, for vaginal dryness, for libido. I mean, there's a lot of things that go into it, so it depends on what's bothering you. Probably no one should just be on hormone therapy forever just 'cause. That's probably the easy message. When to stop, whether to reintroduce. The other message is you probably shouldn't start if you haven't been on them and you've gone through menopause and you're 5 years out, and then all of a sudden somebody says, gee, you should be on hormones because it's good for your heart and it's good for your bones, that you probably won't gain the same kind of benefit, and you might be at a little higher risk from a heart standpoint. So those are pretty complicated answers, but that's the short version. The short version is that everybody should reassess. If you've been on hormones, you kind of need to go back and talk to your doctor saying, what am I really gaining from this? And is it time for me to come off? The upside for the women who are going, I've been on hormones for 30 years, right now in the audience, worrying about that, is that if you stop your hormone replacement, the elevated risk we see with that chronic exposure goes away. And you go back down to a baseline. So that's sort of the up and down part of that story. Great. To go down, to go back to zero back, I think it's after 2 years we see a return to baseline in terms of that risk. So it's pretty fast. The washout is pretty fast. It's the same thing that, ladies, the same thing you were asking about people who haven't had a baby, that it's that change in hormonal environment that is protective to the breast. People who get their period when they're 9 and don't go into menopause until they're 57, they have higher risk for breast cancer. It's all this hormonal exposure. Women who go and have their ovaries removed for prevention, for other reasons, and they go into menopause at 40, they have half the breast cancer risk of someone who kind of carries normal menopause and normal breast cancer risk.
Right. And so someone asked the question, as women are postponing having children, have we seen any impacts? And whoever wrote that question, you asked, as more of us need to use something. And I don't know what that... IVF. Oh, I see. Thank you. And more of us need to use IVF. Do you see any cancer risks involved with that?
So ovarian cancer, from an epidemiologic standpoint, from a population 10,000 feet look, is associated with infertility. But age, as we age, is also associated with infertility. And so the studies get a little confusing because most of the infertility usage in this country is done by women who are sort of outside of their natural pro-fertility phase as we delay our childbearing to finish education and other things. So it's a little hard to tease that out to know if the increase in use of IVF actually is associated with an increase in ovarian cancer. We know that for women who've used the drug clomiphene or clomid, that there are older studies that suggest that those women had an increased rate of ovarian cancer compared to people who did not require those to get pregnant. However, as we move forward in infertility treatments, it's suggested that it's not the treatments themselves, but the intrinsic being not as fertile as we would like to be that actually puts people at risk. And again, I think it goes back to hormonal milieu. There are no current studies that say if you had 18 cycles of IVF that you're at an increased risk of ovarian cancer because you had the 18 cycles of IVF. So, we don't really know. The population data suggests a connection, but we don't have any causal relationship at all.
Great. And just another question. Someone's heard that there might be some reconstructing using stem cell therapy. So has there been any growing of breast tissue, and how far along is that research, if any, and what if there's any increased possible risks of cancer on that site if you use stem cell therapy?
The data on stem cell growing new breast tissue is very new, and so we don't have any definitive information on its usage and as well as potential causing breast cancer. What is currently being used and have shown to be safe and can give reasonable reconstructive results is the use of fat injection with or without processing the fat to condense the stem cells that's present in that particular patient. So basically what that means is that your fat is harvested through liposuction, either abdomen or thigh or the buttocks area. And then that volume of fat may be processed. We take part of it, we process it through a special machine that's been made. And this machine has not been FDA approved. It's used in other countries in Asia and in Europe. And they essentially extract the stem cells from the fat tissue, which normally were, a lot of the investigators who are studying stem cells, they harvest stem cells from fat tissue. And so they extract the stem cells from that volume of fat that we, process through the machine. So it comes down to maybe from, 100 to 200 cc of fat. We discard a lot of that, and it comes down to maybe about 1 cc of stem cells. And then we put that back in, mixed in with the other fat tissue that we liposuction from the patient, and then inject that into the patient for breast reconstruction or for augmentation for non-reconstructive purposes. And the person that I worked with had the opportunity to work with in Japan who popularized this technique, and he has had done studies on the basic science level and has shown that it is effective and it does stimulate fat cell survival as well as regeneration. Have very good results. Normally, typically for fat injection, about 50% or so will undergo fat necrosis or lysis. So we lose about 50% of whatever we put, inject into the breast area. With this new technique of using your own stem cell, concentrated stem cell, most of that, about 80% or so, based on the results that I've seen, that the fat are preserved. So that's the newest.
Lots of new technology that'll come from that. If your parent had cancer, and let's say it wasn't breast cancer, it was colon cancer, are you at risk for cancer? Are you at risk for that cancer? Are you at risk for cancer in general? Anyone know the answer to that? Of course, all eyes go to you, but feel no pressure, okay?
No. So when you have a family history of any common cancer, it has the potential to increasing the risk. We see what's called empirically. So if you have a first-degree relative with breast cancer, with colon cancer, with ovarian cancer, with pancreatic cancer, that to the next generation or to the siblings, they have a slightly higher risk for having cancer. When there are multiple people, and they may not all have the same cancer, so you may have colon and uterine and ovarian, you may have breast and ovarian, you may have all kinds of a whole combination of things that actually are related to a single underlying genetic defect. So those kinds of patterns we try to flesh out and decide what kind of testing would be appropriate. And there are a lot of different genes that can make that vulnerability. Just on the kind of all-comers, so when you have had a family member with a cancer, a common cancer like colon or breast, we use the age and try to judge when somebody, the next generation or the siblings, should start screening, that we ratchet it back about 10 years before that person had their cancer. So if they had colon cancer at 50, and our usual screening recommendations would be to start colon cancer screening in the general population at 50, we would start at 40. One thing I wanted to mention about the ovarian cancer and the study that we have ongoing that Cedars is a part of for looking for those new markers is that if you have a family history of ovarian cancer, even if you don't have the hereditary genetic susceptibility, but just on the basis of having a mother or a sister or a daughter with ovarian cancer, that you would be eligible for this screening trial looking at these blood markers. And so that we invite anybody to come in and get information and participate about that, because we're trying to sort of enrich for the people who are a little bit higher risk.
Great. I want to thank our speakers so much for giving up some of their day to talk to us. Let's give them a hand. What's really clear is over time, there has been a lot of research. There's going to continue to be a lot of research. An organization that I think many of you might have heard about, the Komen Foundation, I found it is really second only to the United States government in funding research and also funding community outreach and programs. And I know our clinic gets funding from Komen to help pay for screenings for folks who don't qualify for Every Woman Counts, et cetera. So there still lots of research to be done and make a big difference. Someone asked about support groups, and there was a number, I believe there was a sheet of paper that talked about different resources for you, but certainly there are many, many support groups out there, whether it's the wellness community, through the American Cancer Association, and I know if you are diagnosed, whether it's through a doctor at Cedars or someone else, there's usually a whole packet of information because it is so important to talk to other people and know that you're not alone in this. So I want to thank everyone for coming. I want to remind everyone to do their evaluation because that's really important because we tend to do this every year. I want to thank again Cedars-Sinai Medical Center and all of the doctors and Logan. I want to thank the National Council of Jewish Women for all their work, and I do want to thank the City of West Hollywood for its support. And we have for each of the doctors a little commendation from the city that just really thanks you so much for being here and for all your work. It really, really is making a difference. So on behalf of NCJW, thank you all very much for being here.